Hi guys, this has been such a great meeting. I knew it was going to be great, but it has exceeded all of my expectations. The weather's been fantastic. It's just been sensational. Our first big live meeting in 2 years. We're going to wrap this up this last day of the meeting with this satellite symposium. I hope you think that we saved the best for last. This is a mature message. This is probably going to be the most clinically relevant presentation that you will hear, I hope, because there's a lot going on in the Parp space. As you know, we have 9 FDA indications in ovarian cancer, and we're studying it in other tumors, including 2 randomized phase 3 endometrial trials. So when and what Parp inhibitors should be used for ovarian cancer, it's all about personalization, and that's what we're here to talk about. I'm joined by my panelists, which I will introduce in a minute. This is co-developed through the Medical Learning Institute, peer review, and supported by AstraZeneca, Merck, and Novocure. Look for some follow-up material during the presentation and during the polling. We'll have an opportunity for some live discussion. We wanted to do this virtually. We have some international attendees here as well as domestic, so this is going to be very exciting. This content is ours. It's independent. It's a CME program. We will obviously use generic names, and it is, because it's a CME, you can get an hour of credit, whether you're a physician, pharmacist, or advanced practice provider, and you will be able to apply for that at the end of the opportunity. So I'm here in Phoenix. I think most of you know that. We have 2 medical schools here in Phoenix, Creighton, in addition to Omaha, University of Arizona, in addition to Tucson. Here in Phoenix, we have residencies associated with both of them. We teach those residents, and I have 7 colleagues under the umbrella of the Virginia G. Piper Cancer Center in Honor Health. So it's my pleasure to be here. My disclosures are here as well as on the website. I'm joined here by my very close friend and colleague, Katie Moore. Katie, say hello and introduce yourself.
Well, hello, everyone. And again, welcome everyone to the last day of SGO. It's been such a great meeting, and I'm so excited to be here presenting with my colleagues today. I'm Kathleen Moore. I'm the Associate Director of Clinical Research and Director of Phase 1 Clinical Trials at the Stevenson Cancer Center in Oklahoma City, Oklahoma. And I also serve as the Associate Director of GOG Partners. And I'm always excited to talk about Parp inhibitors, which is what we're going to be focused on today, in ovarian cancer.
And you're the Energy Ovarian Cancer Chair. I could keep going on. You have so many wonderful titles.
And I have to cut it off at some point. So I just...
and most of these slides are yours. So
yes.
Thank you for contributing not only to the verbal content, but the slide content. One of my colleagues in U.S. Oncology is Jessica Thomas Pepin from Minnesota. Say hello, Jess.
Well, thanks. I'm a gynecologic oncologist in Minnesota here. I operate out of one of the suburbs, Maplewood. I'm so honored to be here in the presence of such wonderful individuals who contribute so much to the care of women with ovarian cancer. I'm very excited. Thanks for allowing me to come.
Thank you. And I'm going to talk about some novel agents and novel devices and agents that you're very familiar with. You know, U.S. Oncology, although practicing in the community, has been very active, especially you and others. So I'm so happy to have you here, and I enjoy working with you and as a colleague, and I appreciate your contribution to these clinical trials. Again, we've all contributed to this. The peer review doesn't have any relevant financial relationships, but we have disclosed ours. We're going to use some unlabeled opportunities. We're going to make that clear that these agents or devices are not FDA approved, as we always do. And these slides are yours. You can download them at peerreview.com/ovarian22. And you can also join us on Twitter at peerreview. So we're going to have sort of 3 brief discussions, one by each of us, and then some questions and answers, and be done in an hour or sooner. I'm going to go ahead and turn it over to you, Jess. I'm excited to hear what you have to say about essentials for understanding PARP inhibition and expert tactics for genomic testing in ovarian cancer. Go ahead, take it away.
Awesome. Thank you so much. So, understanding how PARP inhibitors work really leads us to really understand a lot more about DNA damage and response pathways. We know DNA damage occurs via exogenous or endogenous mechanisms, and it's very important for us to have accurate and efficient repair of our DNA damage. It's essential for function, replication, and maintaining genomic stability. The majority of DNA damage that we see is going to be in the form of single-stranded breaks. Those are primarily operated upon by the proteins that you see here, particularly including PARP via base excision repair. We also will see double-stranded breaks via the accumulation of multiple single-stranded breaks, which tends to be the most cytotoxic lesion. And repair of these double-stranded DNA breaks occurs via two primary pathways, as you can see here highlighted in red. Homologous recombination repair is the primary pathway that we want to see utilized. We can also see repair via non-homologous end joining. These two pathways are independent, but they do share some proteins and signaling. So why is PARP an excellent therapeutic target? And that leads us to head back to understanding a little bit more about double-stranded break repair. This occurs via these two pathways, and the primary Herculean type pathway that we see is this homologous recombination repair. It utilizes sister chromatids, as you can see here. It's high fidelity, error-free, and this pathway is highly dependent on BRCA1 and BRCA2 genes. BRCA1 is important in signaling the DNA damage repair pathways. BRCA2 has a direct repair role in that it recruits RAD51. But we also see at the bottom here, sneakily, PARP actually contributes to and fine-tunes homologous recombination. It also has a tendency to inhibit non-homologous end joining because non-homologous end joining pathway is actually a low-fidelity, error-prone mechanism of DNA repair. So this can lead ultimately to genetic instability and accumulation of further DNA damage. The inhibition of PARP then leads to an increase in non-homologous end joining and pushing in that direction as a primary repair mechanism. So knowing that we can, that inhibition of PARP leads to an increase in DNA damage accumulation, we're ultimately going to see in certain situations increased cell death. So PARP inhibition, as you see here, kind of really exploits or gets into that baseline vulnerability of cells who have inherent DNA repair deficiency. PARP inhibition, as you can see on the left, traps that PARP on those single-stranded breaks that ultimately the accumulation of more and more single-stranded breaks will lead to double-stranded breaks. And in a normal cell, that's perfectly fine. When you have the homologous recombination pathway, that will ultimately lead to cell survival as long as you can rely on that. But when you have lack of that homologous recombination pathway, that will ultimately lead to DNA damage, accumulation, and ultimately cell death. So this is just a further explanation of that exact pathway and what it's getting at as what PARP inhibitors do and the mechanism that has been reported that we all know is the synthetic lethality. So those single-stranded breaks particularly accumulate with PARP inhibition because we're impairing base excision repair. The accumulation of double-stranded breaks and ultimately replication fork collapse will ultimately lead to cell death in those patients who have homologous recombination deficiency. Additional mechanisms that can lead to cell death are via PARP trapping, activation of that non-homologous end joining pathway, and then you get impairment of BARD1 with BRCA. Tumor selective death or synthetic lethality is ultimately what's occurring, and that was our goal, or is our goal in ovarian cancer cells. So here you see the therapeutic index in patients who have homologous, homozygous loss of both BRCA alleles. A particular sensitivity and dependency on PARP for those patients who have that homozygous loss. They have particular sensitivity to PARP inhibitors. Now, BRCA1 and 2, both germline and somatic, are the most common mutations, alterations in patients who have homologous recombination deficiency. And we know that up to 50% of patients with high-grade serous ovarian cancer can have homologous recombination deficiency. However, there are other genes that can contribute, but knowing that such a large volume of patients may have some form of homologous recombination deficiency leads us to know or want to know that status so that we can provide those patients with education and also make sure that we're providing them with the best care possible through targeted therapy. So on the next slide here, you can actually see, as you read from the bottom of the slide up, you have BRCA1 and 2 mutations that are your gold standard for deficiency of homologous recombination. As you look up, from there, not just baseline BRCA1 and 2 mutations, you can also have essentially a phenotype of BRCA mutations. This can either be epigenetic changes, post-translational changes, mutation expression changes via different mechanisms. And then going up from there in the blood loss red in the middle, HRD-ness, you can have different deleterious variants, post-translational losses in DNA damage repair genes that are non-BRCA1 or 2, or even non-DNA damage repair genes that can lead to an HRD-ness. Primarily through the mechanism of loss of homologous recombination repair efficiency. This leads to increased genomic instability and reliance on error-prone DNA damage repair. And lastly, a more global effect can be seen in cancer cells who just demonstrate a PARP-ness. And that can be through even further different deleterious changes, expression alterations, and even depletion of some metabolites. So how do we identify those patients who would demonstrate homologous recombination deficiency? Well, right now we have two testing strategies, either the Myriad My Choice, which gives us a genomic instability score, which is characterized by the combination of loss of heterozygosity, telomeric allelic imbalance, large-scale state transitions. And you see that for patients who are deemed as homologous recombination deficient, their genomic instability score is at or greater than 42 or have a baseline BRCA mutation. Foundation 1 can give us a loss of heterozygosity score and can also identify different patients who may be characterized by homologous recombination deficiency. So this is an excellent timeline that gives us, an idea of different approvals that we've seen through the FDA over the years. After we've seen some outstanding founding studies really characterize which PARP inhibitors can be utilized in patients with high-grade serous ovarian cancer who may derive some benefit. Back to 2014, and we've seen approval via solo studies, aerial studies, NOVA, Quadra, Prima, and Paola, lastly, which we're actually now seeing combinations of PARP inhibitors with other drugs, which can be used together. So the FDA approval slide here is a little bit busy, but it's excellent to have as in your toolbox. You can utilize this at any time. And just important to note is that, particularly for niraparib here, you have dosing for each one of the PARP inhibitors, but niraparib has that different dosing strategy depending on patient weight and platelet count, and that's actually at the bottom of the slide on the right. This has all the approval dates, and this is the particular slide that I would print and put right above my desk in the office. So it's excellent. But yeah, so this gives us a little bit of an idea about baseline knowledge for why PARP inhibitors will actually be efficacious in ovarian cancer.
Well, that's really great. Wow. It's all about biology, I think. The reason that we've been able to be so impactful for our patients is through hard work in the lab, and I applaud those individuals. And then ultimately, as we talked about with you and others enrolling to clinical trials. So let's now unpack the clinical data. I would not identify anyone in the world that's more knowledgeable about this topic than Dr. Moore. So Katie, go ahead and take it away. Good seeing you. Thanks for joining us today.
Nice seeing you as well, and thank you for having me. And mainly, we're going to start off talking about really the most important indication. This is the place where we have the biggest impact and hopefully the opportunity to cure a higher fraction of patients with this disease. And these are the three studies that may set that new standard: SOLO-1, PRIMA, and PAOLA-1. So we'll talk a little bit briefly about each of these. I'm going to start with my personal favorite, although I am a little bit biased, talking about SOLO-1. And just to remind you all, SOLO-1 seems like a relatively recent study because we keep hearing great updates from this trial, but it actually was developed in 2012 and accrued between 2013 and 14. So it was quite a bit ago when you think about clinical trial design. And just to remind you, because it was so long ago, this enrolled women exclusively with BRCA-associated cancers who were in response to their primary platinum-based chemotherapy, and then were randomized 2-to-1 to receive olaparib or placebo until toxicity or progression, or the 2-year mark, at which point the assigned therapy was discontinued, and the primary endpoint was progression-free survival. So this was first presented when we had 41 months of follow-up. I'm showing you here the updated follow-up presented by Dr. Susanna Banerjee. And this manuscript actually was just published for those of you who are interested in Lancet Oncology, showing up a median of 60 months of follow-up. And the important things to note here are really twofold. One, at the 60-month mark, almost half of the women who were allocated to receive up to 2 years of olaparib remain without progression or recurrence, which is pretty phenomenal. We're still following, and we have several more years to call overall survival, but at 60 months, almost 50% are without evidence of recurrence, as compared to only 21% of the women allocated to placebo. The second point I like to make is back up to the left a little bit and look at the 24-month mark. This is where the assigned therapy stopped. And for those of you, and I liked bevacizumab, don't get me wrong, I use it all the time. But when we stop bevacizumab, you see those two curves come back together. We call it the banana sign. Here we don't. So when the treatment is stopped at 2 years, the curves completely remain apart. And so that gives you some, and we can discuss this a little bit later, some comfort in stopping at 2 years. You don't need to sort of bend the rules and treat longer for patients who meet these clinical characteristics in SOLO-1. So this was really unprecedented improvement and a 70% reduction in the hazard of progression or death with use of olaparib following response to platinum-based chemo. But the next question really was, well, that's great. Well, it's better than great. But it only applies to those patients with BRCA-associated cancers. What about everybody else? And so this is where the next two studies and really prominently the PRIMA study come into play. So PRIMA asked the question, well, what's the benefit of maintenance niraparib in everyone? And so it had two co-primary endpoints. First, the progression-free survival in the entire population. So all high-grade serous or high-grade endometrioid histologies were allowed. Similar, they had to have advanced disease and be in response to platinum-based therapy, and were randomized to up to 3 years of niraparib or placebo. And so the endpoints were looking at the entire population. And then the second co-primary endpoint was looking at the progression-free survival in those patients who were deemed homologous recombination deficient by the Myriad assay, a score of 42 or greater, inclusive of anyone that had a BRCA-associated cancer. So they were all classified as HRD. So those were your two primary endpoints. And so what you can see here on the left is the benefit in the homologous recombination deficient population, with a 57% reduction in the hazard of progression or death. So that is phenomenal. And then even in the primary, all the ITT group, it's still a 38% reduction in the hazard of progression or death. So both of these primary endpoints were highly statistically and clinically significant and led to the approval of niraparib following response to frontline platinum-based chemotherapy, irrespective of biomarker. Now, one of the things that happened during PRIMA is that we learned from NOVA, which we'll talk about in a moment, but that was the study from platinum-sensitive recurrence disease and Quadra and others, that there were risk factors that would help us identify patients who were at risk for developing severe thrombocytopenia with the starting dose of 300 milligrams of niraparib. And you heard that already referred to earlier in this session, being weight less than 75 kilograms or starting platelets less than 150,000. So either one of those two, not both, place patients at higher risk for grade 3 or 4 thrombocytopenia. And so during PRIMA, and this was actually a bold and appropriate move, 2/3 of the patients had been accrued, but they made an amendment to go to individualized starting doses. So if you had a patient with either of those two criteria, you started at 200. If they had neither of those criteria, they started at 300. And what this table shows you is the impact not only on toxicity, but the lack of impact on efficacy. So we'll start with the second. You can see the hazard ratio for progression-free survival between fixed dosing, 300 milligrams, or the individualized starting dose. Those confidence intervals completely overlap. So these are not statistically different, and we do not feel that there is an efficacy endpoint or impact of using an individualized starting dose. So that's important. Even more important is that we saw over a 60% reduction in severe thrombocytopenia. It went from 48.3% to 21% with individualized starting doses, and you saw subsequent reduction in other hematologic toxicities as well, really making this a much safer Parp inhibitor to use with individualized starting doses while maintaining efficacy. And then the third study that resulted was Paula. And Paula is a really interesting study because it was an investigator-initiated trial led by Isabelle Rey-Picard from France. So those of you who like to do IITs, you know, you can strive to have a registration-enabling study. It's not the usual, but we did see it here. And really, this was designed because in many parts of Europe and many countries, the only place you can use bevacizumab is in frontline chemotherapy. You can't use it like we do here in the US, basically whenever we want to. You can only use it in frontline. So they said, well, we're not going to give up on using bevacizumab. We want to add olaparib to it. And of course, there's scientific rationale, as we all know, for the combination as well. But they basically said, okay, anyone with a high-grade epithelial, again, high-grade serous or endometrioid, ovarian cancer who's in response to platinum-based chemotherapy, inclusive of some bevacizumab, would then be randomized to continue the bevacizumab with placebo for olaparib or the combination. And the primary endpoint was all comers, which was wildly positive. But I'm showing you the breakdown by biomarker because that is how the indication came down in the US. You can see on the left, this is the BRCA population with a hazard ratio of 0.33, so almost a 70% reduction in the hazard of progression or death with olaparib bevacizumab versus bevacizumab. So an active control, not placebo here. In the middle, you see this group of patients who's increasingly important, you know, in terms of our understanding of BRCA wild type HRD. Again, Parp bevacizumab versus bevacizumab, a hazard ratio of 0.43, so almost a 60% reduction in the hazard of progression with addition of olaparib to bevacizumab versus bevacizumab. And then somewhat surprisingly, although we can talk about why I think this is different than PRIMA, in the homologous recombination proficient group, we did not see an improvement when you added olaparib to bevacizumab versus bevacizumab. And this is why in the US, the indication for the combination is in homologous recombination deficient, inclusive of BRCA alone, and not homologous recombination proficient. So your only indication for PARP there is niraparib. So just to give you sort of an overview of safety, I think we all know this. There are class effects to PARP inhibitors. They're very similar, but they have some subtle differences, with a high preponderance of low-grade fatigue, nausea, and emesis, all of which can be mitigated with setting patient expectations, and medications as indicated for whatever the toxicity is. When you talk about grade 3 or 4 toxicities, which is what I'm showing you here, really anemia is about a quarter of the time. It varies across the PARP inhibitors, but that's sort of my rule of thumb, grade 3 or 4. And then of those, about 2/3 will end up needing a transfusion. It's always good to check iron and folate before you start someone on a PARP inhibitor so that you can replace those nutritional deficiencies and mitigate some of this toxicity. But otherwise, you see very, very low rates of grade 3 or 4 non-hematologic toxicities across the boards, and very low discontinuation of drug due to toxicity, which really speaks to the tolerability of any of these regimens for our patients. Now, this is just a nice decision-making algorithm that you can see that shows how complex it is to really make decisions in the front line for patients in this era. I always say when I was a fellow, which is increasingly long ago, you tried to operate on everyone and you give everyone paclitaxel and carboplatin. And that's about as much as you thought about it. And now there's a lot of individualization of timing of surgery. Everyone should be getting BRCA testing or offered BRCA testing and other high penetrance genes. HRD comes into play. You make a decision about bevacizumab based on your kind of personal interpretation of the data. And then once you have all of that factored in, plus clinical response to the platinum-based chemotherapy, if someone started with measurable disease, you end up with, at the bottom of this algorithm, where if you did not start bevacizumab and you have a patient who is homologous recombination proficient, your option in the setting of response to platinum is niraparib. If somebody is homologous recombination deficient, inclusive of BRCA, you can use either niraparib or olaparib in the setting of BRCA. If you did start bevacizumab and you have a homologous recombination proficient tumor, your option really is to continue the bevacizumab, and that is appropriate. And then if they are homologous recombination deficient, inclusive of BRCA, your option there is to continue the bevacizumab and layer on olaparib. And there's all sorts of nuances to this that we can discuss. So that's frontline. Now, the whole idea of maintenance came from the platinum-sensitive recurrent setting, and this is in fact where all of the PARP inhibitors got their first big confirmed approvals with SOLO2, NOVA, and ARIEL amongst patients who had platinum-sensitive recurrent ovarian cancer, responded to their platinum. So that response to platinum is the key clinical biomarker for anybody that's going to benefit from a PARP. Which is why, as you'll see, the biomarker was important but not essential. And then they were all randomized to PARP or placebo. And all of these studies were positive, as you can see here, with gradations by biomarker, of course, with BRCA getting the most benefit and homologous recombination proficient the least, but no one had no benefit, which is why all of these agents were approved irrespective of biomarker, molecular biomarker, because the clinical biomarker of response is so powerful. However, all of these studies were done in BRCA or in a PARP naive tumors. And so the question now is if it's even relevant, and we'll come back to that point. We do have some kind of newer studies coming out. This is at this year's SGO in 2022 by Dr. LaRue. This is the opinion study, which is just looking at monotherapy olaparib in non-BRCA tumors. So remember, olaparib is only approved as monotherapy in BRCA-associated cancers, and if it's HRD BRCA wild type, it has to be with bevacizumab. This is really trying to build the kind of obvious story for use of olaparib monotherapy in different biomarker groups. And this just adds to that, that database, just showing the efficacy across the molecular biomarkers. And similarly, we have the phase 3 randomized study, MONO-OLA1, which will also be presented, or was presented at this meeting, I should say, by Savitz et al., kind of a similar study in BRCA wild type patients, olaparib versus placebo, with clear benefit. Now, the other thing just to say, because these studies were done before the frontline, is we actually have overall survival data from Solo 2 and Nova, neither of which were powered for overall survival. So we have to acknowledge that there's a lot of crossover, and these are all nominal p-values. But I think at the very least, we can say there's no detriment to use of PARP inhibitor in this setting. And numerically, for olaparib, it was about a 12-month gain, and Nova was about a 7-month gain. Nominal p-value, can't say anything statistical about it other than we didn't harm people, which is always important to say. So I would be remiss if I didn't mention treatment-related myeloid neoplasms with use of PARP inhibitors and really with use of repetitive chemotherapy, because this really isn't specific to PARP inhibitors. It's become front and center because PARP inhibitors work so well and patients live a long time. When you live a long time and get a lot of chemotherapy, you are at risk for treatment-related myeloid neoplasms, which we sort of classify as MDS AML. And so we're collecting this data over time and really starting to understand the true risk over time and with exposures to many types of therapies, inclusive of PARP inhibitors, and maybe even start to understand molecularly who's at risk for developing these disorders, their CHIP mutations, and other abnormalities that may help us tease that out, but nothing to date. But I think the take home really is that the risk, especially when it's used in the front line, is very low. 1 to 2%, mainly because I think the patients do so well that they're not going on to receive as many lines of chemotherapy. We'll follow them over time. And we have to remain vigilant for hematologic abnormalities that don't resolve in an appropriate period of time, and early referral to our hematology colleagues if there's any concern. So this is an ongoing story, relatively low risk, but definitely on the radar for things to watch for as our frontline studies mature. Now, I mentioned earlier several times, in fact, that the studies of PARP inhibitor in the platinum sensitive and kind of quasi-platinum sensitive, if we're talking about aerial 4 space, are important, very important, but kind of questionable relevance because they were all done in PARP naive populations. And so appropriately, and kind of anticipating that issue, the AREO study was designed now many years ago to study this question. And basically what this study is a randomized phase 3 trial that took patients, women who had had prior PARP inhibitor, one course, and then had recurred and were felt to be platinum sensitive, received a platinum and responded to that platinum, and then they could come on the study and be randomized to olaparib or placebo. And they kind of made up, appropriately, someone had to make it up, some classifications for prior response or prior benefit from PARP. So if you had a BRCA-associated cancer, you had to have been on the PARP at least 18 months for first line or 12 months in the platinum-sensitive space. And if you were BRCA wild type, it was 12 and 6 months, respectively, just so you enrolled folks that had some hope of benefiting and excluded patients who maybe progressed 3 months into a PARP. So that's rational. And the endpoint was progression-free survival. And this was presented recently. It's not been published yet, but this was a kind of positive negative study. It's very interesting. The hazard ratios are phenomenal, 0.43 and 0.57 in non-BRCA and BRCA respectively, which sounds, you might think, well, gosh, I would have thought the BRCA cohort would have done better. But just like in the platinum sensitive story, response to platinum is probably your most important biomarker in this space for response to subsequent PARP. And very germane to this patient population, almost half of them had received 4 prior platinums. So this is an amazing population of women that we really need to understand better. It's not first or second line platinum, 4 lines, and they were still responded again, and then some fraction of them got a benefit. And so I think this is a positive study. Do I think it is the new standard of care that you must use? No. Is it an option, and do you have permission to use it now? Yes. I really want to know who the women are in the tail of these 2 curves, molecularly, clinically, so we can better understand who will benefit, because clearly 20 to 30% of them benefit very much. And the rest we need to move on to newer assets you're going to hear about from Dr. Monk that work irrespective of prior exposure to PARP inhibitors. So this is an important first study that raises probably more questions than it answers, but it was a needed first step. So to end off, just again, thank you for having me. I think that in the front line is where we should be using PARP inhibitors. That is very, very clear. This is not something you want to sequence or wait. You use your best drugs in the front line. So PARP inhibitors with and without bevacizumab in the maintenance setting has been transformative certainly in BRCA-associated cancers, but I would also argue in BRCA wild-type HRD. These are transformative hazard ratios. And we really can't be dismissive of the homologous recombination proficient group as defined by PRIMA, a very high-risk clinical group of tumors who responded beautifully to platinum, and they did get a benefit. A 32% reduction in the hazard of progression or death is clinically relevant. So the clinical biomarker that is very prevalent in PRIMA kind of overcomes the molecular biomarker of homologous combination proficiency. And so it is something to consider there, although it's an area of clinical equipoise, I acknowledge. And then I think the OREO data gives us some data on the reutilization of PARP inhibitors. It really tells us we need to keep developing new and better agents, which you're going to hear about next, so that we can keep helping women incrementally live long, high quality lives. However, there is a population who benefits, and I want to know who they are so I can sequence this in appropriately, and hopefully more data will come out on that as patients are followed longer and molecularly characterized. But with that, I'm going to turn it over to my good friend, Dr. Monk, who will take us home. Thank you.
Katie, that was great. Every time I listen to you, I learn, 4 or 5 new things. So that was really good. And, this field has evolved since the accelerated approval of olaparib in December of 2014. And it will continue to evolve. And that's really what I'd like to talk about now, sort of the new approaches into combinations and novel therapies. So the first thing I'd like to focus on is these upfront trials that all of you know about. In fact, almost all of you probably enrolled to them. There are these 4, Key-Link, which is GOG 3036, which is pembro olaparib, FIRST, which is niraparib dostarlimab, DUO-O, durvalumab, and olaparib. Olaparib is shared between those 2 first and third rows. And then Athena, which is pure maintenance, nivolumab and rucaparib. And these studies are all complete enrollment. We'll see what they show. Some of them require bevacizumab and some don't. And as I said, Athena is a pure maintenance. So we'll see what that shows. Also Athena mono, which is a similar design to PRIMA, should report out before the Athena mono, which is the nivolumab combination. And then there's some of these phase 2s that you see there, looking at novel combinations to inform what we're doing in frontline. I just want to sort of highlight a couple of these frontline very large studies, Key-Link or GOG 3036 or OV43. This is a big deal. And as you know, that this combination of pembro in triple negative breast is approved, and maybe PARP will make it better. And there's a lot of preclinical data from Topasio, Avanova, that would sort of inform this. So the studies are done, and we're going to know, and we got 4 shots on goal. And the subtleties, not only in the use of bevacizumab, not only in the integration of with chemotherapy and pure maintenance, but also in the biomarkers. So I think we're going to have a number of shots on goal, and we should know relatively soon. And this is Athena. Again, 2 components, Athena mono, which is placebo plus versus rucaparib in all comers. Again, very similar to PRIMA, but with a different PARP inhibitor. And then separate study where multiple comparisons are controlled for with rucaparib versus rucaparib nivolumab. So the next wave is really in recurrent ovarian cancer. This idea that genomic stress, very nicely done, Jess, causes double-stranded and single-stranded breaks and is mitigated by PARP, but other enzymes, particularly other DNA damage response genes such as P53, WEE1, ATR, AKT, very novel. And so as you traffic through these studies, which I'm not going to review in great detail, notice that some of them are alone, such as WEE1, which I'll show you a little bit. Some are in combination, also WEE1 ATR. Some are with chemotherapy, AKT and weekly paclitaxel, Profecta, another GOG study. And then some are big randomized phase 3 trials like EPIC-O, which is a PI3K. So we're trying to overcome PARP resistance, and we're trying to make PARP sensitive patients even more sensitive. And that's active field of design. And I can't really get into it here. I just want to do some highlights, but I want to spend a few minutes on tumor treating fields, a few minutes on antibody drug conjugates. And again, I don't have time to talk about gene therapy either. As you know, Ofragene, Obadavovec, or Ofragene, that's what we should call it, VB111, that study, OVAL, has also completed enrollment. So I'm not going to talk about gene therapy either. But your hard work is leading to discovery, and many of these trials have completed enrollment and should report within the year. So you saw Shannon Weston's very nice study effort, which showed in PARP exposed patients, both single agent adavosertib and the combination was active. A big deal. Double DNA damage response medications, which overcame either acquired or primary PARP resistance. And you'll see ZN03, another study within the GOG that we're working on this pathway, and obviously adavosertib is going forward. So ZN3 is another WEE1 inhibitor. And you got ATR and AKT and PI3K, some in single agent, some as combinations. I just wanted to show you this one slide because I liked it a lot. This idea of an ATR inhibitor, ceralasertib with olaparib, very small cohort, but showed a 45% response rate, again, in PARP exposed patients, which is, Dr. Moore-Katie said, is almost everyone these days. And then devices published this week, if you didn't see it, thoracic mesothelioma with tumor treating fields, 2 positive phase 3 trials in glioblastoma multiforme. This idea that living cells can be impacted by these alternating electrical fields that interfere with mitotic activity and can be added to chemotherapy generally or as a single agent, GBM, and show therapeutic benefit. So very novel, but it works in historically chemotherapy resistant tumors, thoracic mesothelioma and glioblastoma multiforme. So this is very well thought out, both frequency dependent tumor treating field inhibition as well as intensity dependent tumor treating field inhibition. These are in vitro data. We needed to do a preliminary, I mean Professor Vergote and his colleagues in Belgium showed that this could be tolerable. Strap on to the abdomen where these arrays, wear a battery pack, keep it on for about 18 hours a day, again, with weekly paclitaxel versus weekly paclitaxel, and see what it shows. So this is the phase 2 study, small cohort published in our journal, but ultimately a phase 3 trial, again, which you and I enrolled to, 540 patients. And again, it's done. It's done. So we've worked hard within the European network, within the GOG, domestically and internationally, to do a number of pivotal trials, some of which are finished, and we're very excited. So we'll see what this shows. Platinum-resistant recurrent ovarian cancer, weekly paclitaxel versus weekly paclitaxel tumor treating fields with a survival endpoint. Stay tuned. And I get it, we live in an antibody drug conjugate world. You saw what we did with tisotumab vedotin in cervical cancer. That was the first one approved. We're here to talk about ovarian. Katie, you've worked very hard on mirvetuximab soravtansine, an antibody drug conjugate against folate receptor alpha. Very nice study published in Annals of Oncology, Forward 1. Very nice study published by Dr. O'Malley to add it to bevacizumab. And then ultimately you saw presented at this meeting, SORAYA, in Bev-treated, beyond PARP if you were BRCA, 32%. Blinded independent central review with a long duration and some complete responders likely will lead to an accelerated approval, with the confirmatory trial being another study, Katie, that you're leading, another GOG study called Mirasol. There's a nice trial in progress abstract here. You see it, abstract 297. And then Angela Secord and others are running this platinum sensitive single arm study called Picola. So we did forward one, close, needed to refine the biomarker. We did Soraya with the new biomarker, bingo, presented at this meeting. And then we have the confirmatory trial for international approval. And now ultimately bevacizumab as a combination, O'Malley, and now this platinum sensitive opportunity. So this is a very extensive development plan. There are other antibody drug conjugates. This is a different target, NaPi2b, UpRi, upifitamab riluzole. I did better with that name, and has a higher drug to antibody ratio. This does not have the level of neurotoxicity that mirvetuximab would have, does not have the level of ophthalmologic toxicity. Again, I don't mean to make comparisons, but this is a different mechanism and a different antibody drug conjugate, again, being explored in platinum-resistant recurrent ovarian cancer. Debbie Richardson had that nice oral, which you saw, and I sort of presented some more data in abstract 319 about dose optimization. So these patients are on treatment for a long time, and you can see that from the 43 milligram group to the 36 milligram group, there is more tolerability without a decrement or a drop-off in activity, and specifically a reduction in the pneumonitis. So moving forward, many of the studies are going to use this 36 dose rather than the 43. So let's go ahead and have some questions. I have a number of them here. We have plenty of time. Katie, it struck me when you said in Solo 1 that there was no additional benefit beyond 2 years, and I would support that. Jess, you know, it looks like much of the benefit is actually in the first year. Is there any rationale to do a shorter than 2 year, let's say in a Solo 1 population, or do you think we have to do 2 years? And I know it's unknown, but how do you do this in the clinic?
I would say I would not want anyone to leave thinking that it's okay to use a shorter course.
Okay.
I don't think there's any data to justify that. And I think 2 years and stopping at 2 years in absence of disease that you can see, you know, there are patients who do continue on,
Right.
Is okay. But I go to 2 years, and in the PRIMA, I think the hard thing is in the PRIMA population, you can go to 3 years. And so you have to kind of make that shift for patients who are BRCA,
Right.
you know, you go 2 to 3 years. But you ask a good question. I don't know how we'll ever study it, but if you look at it's just a back of the napkin sort of analysis, you look at the slope of the curves in the PARP arm, the experimental arm, and the control arm. And when they become equal at that point or a little beyond is sort of where that means the event rates have sort of equalized.
Right.
And you have to wonder if you're getting any benefit from
That's the
whatever
year.
your experiment is.
Yeah.
And that happens about 18 months in.
18 months. Okay.
For Solo. It's like 16 months in PRIMA, although you don't have enough follow-up yet. So I think we have to redo that when there's more follow-up on PRIMA and Paula. It's a little unfair to do it at this point. So I definitely don't think there's rationale for going beyond 2 years in a Solo-like population, which is very different than PRIMA, but I would not use shorter.
Okay, that's helpful. So Jess, I'm going to ask you this question because Katie already said she has a preference. So in the BRCA mutated patient, you can either give PRIMA, assuming there's no Bev, or you can use olaparib Solo 1. How do you make that decision?
Oh, absolutely. I mean, you know, obviously understanding their HRD status, you know, may just is an easy clinical method of choosing one versus the other.
Yeah.
But you know, side effect profile and knowing that you get that higher rate of thrombocytopenia with niraparib, you know, both are very tolerable. Olaparib, has so many more indications. I think we have a lot more experience with it, and I think a
Yep.
lot of us may tend to go in that direction. But you know, a lot of the data coming out for niraparib is also exciting. But I think you want to get as much data about your patients as possible, know their status, but also look at them individually, their personal makeup. And also think about those toxicities for each patient, and they are a little bit different for each of those drugs.
Does the once daily with niraparib make it easy? Because when I use it, I use it at night with a small meal and sometimes a sedating antiemetic. Does that have leverage or traction with you, or not really?
I think that would be reasonable for certain patients. I've utilized that. Similarly, I think that's very reasonable, and also having a good, extensive conversation with your patients about their preferences with taking oral medications and how they're tolerating everything. Mm-hmm.
So let me get to that with Katie. So Katie, you and I are very passionate about, all of us, PARP inhibitors in BRCA and even HRD. I mean, it's really important, but you have to sort of counsel the patient about the side effects. But if you are too strong as the side effects, every patient thinks they're cured. And so how do you balance this efficacy enthusiasm with a fair and balanced assessment of adverse reactions? I'm really interested in this answer, Katie.
Well, I think it's, as you say, you kind of, and I showed that algorithm.
Yeah.
So you have a patient who presents, generally they don't feel good. They're so overwhelmed. They've been given this diagnosis. So you kind of have to get them rolling and feeling better, get their molecular status back, see how they're responding. And then I initiate that conversation about maintenance, if I haven't started bevacizumab around cycle 3. And honestly, I'm pretty straightforward with patients about the known outcomes for advanced ovarian cancer. I say we're going to be special friends for many, many years, but the likelihood that this comes back is, over 80%, and it may be 100%. Mm-hmm. And so my job is to try and do everything I can up front to prevent that or keep it at bay as long as possible. And so we have the strategy of a maintenance therapy after. So I start planting those seeds pretty early.
Nice.
But I don't really get into the nitty gritty of the counseling until I'm kind of close to the end. And then it's several detailed conversations to really set expectations. The first 6 to 8 weeks, they don't feel good generally.
Yeah.
Mm-hmm.
So you have to just tell them that, because they expect to feel good coming off chemo. They're done with chemo, thank goodness. And then I'm like, well, 6 weeks, you're going to feel kind of crappy, but then it's going to get better. Mm-hmm. So yeah, I sort of set them up that way. And then they're like, oh, it wasn't as bad as you said. But I really try to set them up, and then when they feel better, they cruise. So
and the worst toxicity is dying of recurrent ovarian cancer, obviously. So right. I hear you. So Jess, the decision to use bevacizumab is made generally before the decision to use a PARP inhibitor. And if you don't use bevacizumab, you're never going to get to PALA-1, right? I mean, I guess you could start the bevacizumab in maintenance, but as all of us know, generally it started with chemotherapy. How do you make that decision to use bevacizumab with the ultimate idea that if they're HRD, you're going to get PALA? If they're not, you're just going to continue the bev. But that decision to use bevacizumab is critical. And I find people still evolving that decision, even though bevacizumab was approved in June of 2018. Tell us how you make that decision.
I think, you look at the volume of your disease, the different characteristics about ascites, what are you seeing for each particular patient? And honestly, while we see some of those banana curves for bevacizumab, we've also seen data that has shown that getting bevacizumab overall has substantial benefit for these patients. And I really want to get that to those patients who have that substantial tumor burden or profound ascites. I want to help them feel better. And I know that it's an outstanding adjunct, and that can help us bridge, perhaps, it can help us bridge into the payola patients who are HRD positive. But really, looking at that disease volume up front is the primary.
Good point. This is a tough question for you, Katie, so I'm going to ask it to you. And I'm glad that I'm not on the other, that the roles are not reversed. does PARP inhibitor induce platinum resistance? In other words, if you were to look at NOVA, Ariel 3, or Study 19, Solo 2, if you got PARP, are you less platinum sensitive in the next line of therapy than if you get the placebo? And if that's true, maybe you don't know, what does that mean if it is true that you induce platinum resistance with the use of a PARP inhibitor, particularly in platinum sensitive maintenance?
Yeah, I think that's one of the most important questions that we need to really understand. And we don't have great data yet. We need the data from frontline, number one. So we have sort of exploratory data in the Solo 2, really from Solo 2, where Fresnel et al. Did an unbalanced, it was not company supported, it was an unbalanced sort of a look at patients on Solo 2 who, you remember, got PARP until they progressed.
Yeah.
They progressed on a PARP and then went on to receive platinum. They showed a 7 versus 14 months progression-free survival in the olaparib versus placebo arm. And then you showed actually Stephanie Wethington's work, Dr. Wethington's work, which was ATR olaparib in that same population, mainly who had progressed on a PARP, and the median survival is about 7 months. So there's this question of, if you progress on a PARP, there are overlapping resistance mechanisms with platinum that may make you less likely to respond. So that brings our earlier discussion more into focus, that if you can, you really should stop. Because I think if you stop the PARP, you get the benefit from the PARP, and you stop the PARP, and hopefully they don't recur. We'll see in Solo 1. Most others will recur. But if they don't recur for 2 years or 3 years, do they have a negative impact on platinum? We don't know, but hopefully we'll get that subsequent data from Solo 1 and Prima and Paula. It'll all be exploratory, but cumulatively it should give us a sense. I am worried about that. I'm not going to lie.
I know. And then this last question, I think, Jess, you were a high enroller in Innovate, right? Tell us about these tumor treating fields and what your experience has been with that. Is it tolerable? I mean, there's some skin reactions, right?
Right, exactly. So what we saw is early on, as evidence from prior data, prior studies, is that patients had to have algorithms. You know, if they saw rashes related to the devices that they wore on the front and sides of their abdomen, in general, you could mitigate those.
Okay.
Moving the arrays around, you know, utilizing steroids and topical creams as needed, taking a break. You know, perhaps we needed to alter the time that patients were wearing those arrays on their abdomen. Many of those could be mitigated. And then it also required a substantial amount of counseling. And so one thing I noticed in my office is having counseling and counseling early, being there with your patients, helping them understand, you know, trying to get them through, because the data, you know, this could be completely innovative and excellent for these patients.
Well, I appreciate both of your participations today. I appreciate your commitment to clinical trials. I appreciate the audience for sticking with us here. I also appreciate your participation in submitting those questions. I encourage you to complete and submit the post-test and evaluation for credit. Download the slides. There's also some practice aids that are integrated in there. Watch the replay of the event if you want, and also share it with your colleagues, and obviously join us on Twitter. So thank you. It's been my pleasure to see you here in Phoenix. This has really been a great opportunity, and hope to see you guys again soon, maybe at the next meeting, maybe ASCO. So thank you, and so long for now.